So today I would like to discuss about diabetes insipidus. So before going into diabetes insipidus, let us discuss what is the antidiuretic hormone, which is nothing else but a hormone which is produced by the hypothalamus stored in the pituitary, the key regulatory hormone of water reabsorption in our body. They mainly acts on the collecting ductules of the kidney. So as the name indicates, antidiuresis. So it prevents the excess loss of water through urine. Remember, the major stimulus for antidiuretic hormone is whenever there is an increase in plasma osmolarity. This ADH hormone will act on the V2 receptors on the collecting ductules and it enhances or increases the water reabsorption and the plasma osmolarity is brought to normal. Remember, we have one more receptors called as a V1 receptors, okay, which are mainly present in the blood vessels and they have a vasoconstrictory role, and that is why we use in vasopressin analogs are used for the treatment of esophageal varices. Coming to a condition called diabetes insipidus, which may be either central or nephrogenic diabetes insipidus, where there is an inadequate ADH levels in the body. So what will happen? ADH won't be there. So more water will be excreted in the urine. The patient presents with polyuria. That is why we say it is diabetes insipidus, because in diabetes also the patient have complaints of polyuria, polydipsia. Am I right? Yeah. And since the patient is losing more water in the urine, the patient will feel thirst. So even polydipsia is also one of the symptoms of diabetes insipidus. So remember, in diabetes insipidus, there are two varieties. One is cranial diabetes insipidus, who called as central diabetes insipidus, and the second one is what we call as nephrogenic diabetes insipidus, which is like type 2 diabetes mellitus. What is the problem in type 2 diabetes mellitus? Insulin is there, but the receptors are wrong. Here also, ADH hormone is there, but the receptors are insensitive to ADH. So what are the causes of cranial diabetes insipidus? It may be either congenital, associated with brain tumors like pituitary adenoma, craniopharyngioma, associated with Sheehan syndrome, any trauma or surgery of the pituitary. Coming to nephrogenic diabetes insipidus, it is mostly because of drugs: lithium, democlocycline, liposomal amphotericin B, okay, methoxyfluorine, which is an halogenated anesthetic, okay, aminoglycosides, platinum compounds like cisplatin, oxaliplatin. All these drugs causes nephrogenic diabetes insipidus. So what are the clinical features in case of diabetes insipidus? There will be increased plasma osmolarity. There will be hypernatremia because there will be loss of pure water from the body. The urine osmolarity will be decreased. So the urine will be always diluted. Okay, it will be never be concentrated. Okay, the urine will be always diluted and it will be never be concentrated, because the urine osmolarity is less, right? Yeah, the plasma osmolarity is high, plasma sodium is high, okay, but there is very high urine output, urine osmolarity is low, urine sodium is low. So this is actually the classical picture of diabetes insipidus. So remember, what is the first test we will do when you suspect a patient of diabetes insipidus? We will do water deprivation test. We will admit the patient to the hospital. We say, don't take water for some 24 hours, okay? Or don't take water for some 12 to 24 hours. That is given in some textbooks. So what we'll do, even after that, we will see whether the urine output is reduced or not. If the urine output is reduced after complete stoppage of water, it indicates the patient is having psychogenic cause of polyuria. Okay, psychogenic cause of polyuria. At the same time, okay, the patient urine output is high, we will do something called as desmopressin stimulation test. High dose of ADH will be injected to the patient or given to the patient, and we will see if the patient's urine output, whether it is increased or decreased. If it is decreased even after giving ADH, that means what? The problem is in the pituitary. So it is central diabetes insipidus. If it is improving, the patient's urine output is high after giving an injection of ADH, it is nephrogenic diabetes insipidus. When the cranial diabetes insipidus, there is a deficiency of ADH, so the treatment is desmopressin analogs. In nephrogenic diabetes insipidus, we can give thiazide diuretics. Amiloride is the current drug of choice we use for nephrogenic diabetes insipidus. We have another condition called as solute diuresis. What do you mean by solute diuresis? I told in diabetes insipidus, the urine osmolarity is less. Less means less than 250 milliosmol per kilogram. Whereas in case of solute diuresis, the urine osmolarity will be more than 300 milliosmol per kilogram. Okay, that means more solutes are being excreted in the urine. So when it comes to diabetes insipidus, know what is the role of ADH, what are the V1 and V2 receptors, where it is located, then polyuria, polydipsia, the symptoms, then plasma sodium is high, plasma osmolarity is high, polyuria will be there, urine osmolarity, urine sodium will be less, Causes of cranial and nephrogenic diabetes insipidus: water deprivation test, following that desmopressin stimulation test, then the treatment, which is desmopressin in case of cranial, and amyloid, which is the thiazide which are used in the treatment of nephrogenic diabetes insipidus. So these are the points you have to remember as far as diabetes insipidus is concerned.